Hello, and welcome to the ASCO Journal of Oncology Practice podcast. This is Dr. Nathan Pinnell, medical oncologist at the Cleveland Clinic and consultant editor for the journal. For those of you who've been frequent listeners to the JOP podcasts over the last 5 to 6 years, you'll notice a change today, that Dr. Bob Miller has stepped down as consultant editor and has taken a new role at ASCO. I want to thank Bob for doing such a superb job over the years on these podcasts, and I promise I will do my best to fill his impressively large shoes. Moving on to the topic at hand, we are all aware that the costs of healthcare in the United States are high and continue to rise, with current healthcare spending at an astonishing 16% of GDP. With an aging population and the constant introduction of new and expensive treatments, cancer care is likely to be an increasingly important contributor to healthcare spending. One of the strategies being tested to bend this cost curve is to move away from traditional fee-for-service payments through the use of alternative payment models. My guest today is Dr. Ron Kline for the Centers of Medicare and Medicaid Services. Dr. Kline was gracious enough to participate in this podcast, and while I need to note that his commentary had to be approved by CMS prior to publication, we still think this conversation has value and provides good context for the article. Today we will be discussing his paper, Centers for Medicare and Medicaid Services, using an episode-based payment model to improve oncology care, published electronically ahead of print in the JOP on February 17, 2015. Dr. Kline is a pediatric oncologist who is currently a medical officer in the Patient Care Models Group of the Center for Medicare and Medicaid Innovation. In 2013 and 14, he served as a Robert Wood Johnson Foundation Health Policy Fellow, and prior to that was the medical director of the Pediatric Division of Comprehensive Cancer Centers of Nevada. Dr. Kline, thank you so much for joining me.
Great. Thank you so much for having me on the podcast today. It's a privilege to talk about our oncology care model. Our program team has worked very hard on this model, and we think it's going to be very successful, so we're very excited to talk about it. The overarching goal for HHS is better care, smarter spending, and healthier population. Alternative payment models are just one way of achieving that goal. These models are really just a fancy way of saying that some portion of physician payments are linked to the quality and efficiency of the care we provide. Physicians, we are used to being accountable for the care we provide to our patients, so I believe these models are consistent with our training, consistent with our values, and consistent with our ethics as physicians. In 2011, no Medicare payments were based on these models, and by the end of 2014, greater than 20% were. So we're well on our way to meeting these goals. The new oncology care model being just the most recent example of an alternative payment model.
No, that's great. This is very topical. I was recently reading that CMS released a goal to have alternative payment models accounting for 30% of Medicare payments by 2016, moving to 50% by 2018, which seems pretty ambitious. Do you think that's realistic?
Yes, as I said before, in 2011, no Medicare payments were based on these models, and by the end of 2014, greater than 20% were, so we feel we're well on our way to meeting these goals.
So can you talk a little bit about why the current fee-for-service system isn't really working to control costs, and how alternative payment models have the potential to slow the growth of healthcare spending in the United States?
Sure. Well, I've been a practicing pediatric hematologist oncologist since 1991. So I spent my career to date practicing under the managed care model of care, where various payer entities try to decrease spending by micromanaging my care of patients. The new alternative payment models leave the care of our patients to us as physicians, but incentivize us to use our independent judgment to provide care in the highest quality and most efficient way possible. Of the two, I much prefer this latter approach and believe it has a much greater ability to slow healthcare spending by properly incentivizing physicians and healthcare systems to eliminate unnecessary spending.
So tell me a little bit about the oncology care model developed by the CMS. How is this supposed to work?
Well, the OCM, as we like to call it, is a 5-year multi-payer model that's designed to change the way oncology care is delivered in the United States. It combines payment system changes with quality measures to incentivize patient-centered, high-quality, and high-value oncology care. In addition to fee-for-service payments that physicians are familiar with, there's a monthly per beneficiary per month payment, what we refer to as PBPM, of $160 that is intended to pay for additional beneficiary services such as care navigation and 24/7 access to a clinician with access to the patient's medical record. There's also performance-based payment for which practitioners are eligible if the total cost of care for a patient during an episode of care is less than a risk-adjusted target price. These performance-based payments are also affected by practice's outcome on various quality measures. So the additional services paid for by the PBPM will allow practices to provide services consistent with a medical home model. The performance-based payments make practices accountable for the total cost of care for their patients like an ACO, And one of the practice requirements will measure how often patients receive therapy consistent with national guidelines. So we incorporate all of those elements into the new oncology care model.
Yeah, I thought that was very interesting, the way you mentioned that you've blended various potential models for alternative payments, including the patient-centered oncology medical home. I have to admit, I've never really understood that term all that well, but something about using the patient navigator to coordinate care, is that partially how that model will work?
Sure. Patient navigators or patient navigator functions are one of the practice requirements for a practice participating in the oncology care model. And this is something that oncologists know well, and it's been a long-standing complaint of oncologists that there are many services that they provide that they're not paid for under the present fee-for-service system. The $160 PBPM is an attempt to address this complaint and to support the particular enhanced services required for participation in the model. One of these services is the provision of patient navigation services, as you mentioned. Another is 24/7 access to a clinician with access to the patient's medical records. And a third is the increasing adoption of electronic medical records and meaningful use requirements over the first several years of the model. Practicing oncologist, I and certainly your listeners appreciate how complex oncology care has gotten over the last several years. If you add a couple of comorbid conditions requiring care by different specialists, a primary care physician, and perhaps a radiation oncologist and a surgeon, the demands of communication, timely sharing of scan and laboratory results, and the scheduling of appointments can become quite overwhelming. Now, if you imagine an elderly beneficiary, perhaps living alone, without access to transportation, then you can appreciate how important care navigation is. I personally experienced in my family in watching my wife care for her 83-year-old mother and her mother's 98-year-old partner. Yet, without this communication, care coordination, and scheduling of supplementary services such as transportation, medical care is compromised and the patient experience suffers. The requirement for the provision of patient navigation services is intended to address this well-known deficit in medical care, and the per beneficiary per month payment is intended to compensate practices for the provision of these services.
No, I think that's a great idea, and that's certainly one of the major criticisms of the current fee-for-service model. So one of the elements of the OCM is that it evolves around so-called episodes of care. Can you tell me a little bit about this?
Sure. Well, basically, episodes of care are 6-month periods of time that begin with the administration of intravenous or oral chemotherapy, and patients may initiate new episodes of care as long as they continue to receive chemotherapy after completion of the 6-month episode. So this is really basically a time period that we can measure and use as a way to provide target payments for our performance-based payments. You may ask how we came to the 6-month period of time, and the way that occurred was that in examining Medicare spending on cancer patients as we designed this model, we noted a peak in spending at approximately 2 to 3 months after the initiation of chemotherapy and a leveling off after about 4 months. So the 6-month episode of care seemed like a natural breakpoint to choose from for these episodes.
Okay, yeah, that was a question I was curious about, is where the 6 months came from. That seems like a reasonable time to pick. And then if I was going to be running a practice that wanted to participate in this program, so what are some of the expectations and some of the things my practice would need to do to participate?
Well, there are basically 6 practice requirements for participating, and a couple that we've mentioned along the way. The first is 24/7 access to a clinician with access to the patient's medical records, and we hope that by doing this, we decrease unnecessary emergency department use and unnecessary hospitalizations. The second is patient care navigation, the navigation functions as we've discussed. The third is the increasing use of electronic medical records and meaningful use requirements over the first several years of the model. The fourth is documenting and using the 13-point Institute of Medicine care plan for oncology patients, which is intended to demonstrate best practices in oncology care. The fifth is following nationally approved guidelines. And the sixth is utilizing data for quality improvement. And our expectation is that we will work closely with these participating practices to improve the quality and efficiency of the care they provide, while at the same time they're being financially compensated for the additional costs they incur, as well as the performance-based payments they're eligible for if they're successful in reducing the cost of care while preserving the quality of care. We intend to have robust quality and outcome measures to ensure that cost savings do not result in care stinting or reductions in necessary and high-value care. We intend an active learning process that shares best practices among the participating provider groups as well as other educational activities.
So getting down to the nitty-gritty details, how are the actual payment amounts for these episodes going to be determined?
Okay. Well, the payment benchmarks will be calculated using risk-adjusted expenditures that are based on historical data, and these benchmarks will be trended forward using medical inflation or some subset of medical inflation measure to the current performance period. Medicare then takes a discount that Medicare retains as savings in order to generate the practice target price. And as I said, the benchmarks are practice-specific, although we use regional and national data to increase precision for target prices for practices with a low number of episodes. In the first model year, we will risk adjust our episodes for characteristics that predict Medicare expenditures, but in the first year, these will only include information that's available as part of the Medicare administrative claims data. For example, beneficiary characteristics such as age or gender, episode characteristics such as whether this is a first or subsequent episode for treatment, disease characteristics such as the type of cancer and the types of services that are furnished, such as whether they include radiation oncology or not. Once the model begins, we will also collect additional information from practices, including cancer staging information, certainly inclusive of many of the molecular mutations that now define care, and we will consider adding those as risk adjustment factors in future performance years of the OCM.
So it does sound like you're thinking ahead to some of the changing technology and treatments going forward. Is this something that's going to be looked at as the years go by, if there's increasing costs of various drugs and treatments? Sure.
We're definitely very aware of new technologies, some very expensive medications that have come down the pike recently that determine how certain diseases are treated. We know that there are many similar drugs in the pipeline and that this is going to affect the benchmarks. So we are definitely aware of this problem. We are actively and energetically working to find a good solution to this problem, one that doesn't penalize the practice for using state-of-the-art care, while at the same time continues to encourage the efficient use of medications. But definitely something that will be addressed before the model starts.
So in your paper, you mentioned 2 voluntary risk arrangements that practices can participate in. Can you tell me a little bit more about these?
Sure. We want it to be as flexible as possible to encourage practices to participate. So we have 2 different types of risk arrangements. There's a one-sided risk arrangement where practices can receive performance-based payments if they reduce expenditures below target prices, but are not financially responsible for spending that exceeds the target price. There's also a 2-sided risk arrangement where participating practices are rewarded for reductions in expenditures below target prices, but are also responsible for costs that exceed the benchmarks. The 2-sided risk model is not available to practices until a 3rd model year, so practices will have experience with the model and their costs before electing this arrangement. In the one-sided arrangement, reductions in expenditures must exceed 4% of the benchmark before performance-based payments are made, while in the 2-sided arrangement, they must only exceed 2.75% before payments are made. So the reward for taking 2-sided risk, potential downside risk, is a lower savings hurdle to exceed before performance-based payments start.
Okay. And I understand that they'll be able to switch back and forth between these if it turns out that it's not working out to their advantage.
They can switch back and forth semi-annually.
Okay. So another thing that I thought was very interesting is you mentioned involving a multi-payer approach to this program. So not just looking at Medicare payments, but also potentially private insurers and Medicaid as well. How is that going to work?
Yes. Well, as you know, Medicare fee-for-service beneficiaries compose approximately 50% of the oncology population, of the adult oncology population. So they are a fairly significant population for any practice. At the same time, we wanted to leverage our model to increase even beyond that number, the number of patients involved, so that we could encourage practice transformation on the part of participating practices. When we've spoken to commercial insurers and other payers, we've learned that they too are very concerned about providing high quality and efficient care to oncology patients. And by increasing the number of patients in the practice that are using this model, we feel that we'll be able to leverage the ability of practices to transform the care they're providing. By participating in the oncology care model, the payers will have the opportunity to improve the care for their members, lower costs, and engage with quality and cost data that will inform changes to quality monitoring and payment delivery.
So you're going to be talking so individual insurers will be able to apply to participate in the program? Is that how it's going to work?
Correct. Other insurers, commercial insurers, Medicaid programs can participate in the program. If they want to participate, the letter of intent will be due. We will need to receive a letter of intent from them. And for participating practices, we will need a letter of intent by April 23rd, with final applications due by June 18th.
Okay. And speaking about applying to participate, so if my practice wants to participate in the program, how would we go about applying?
Well, as I said, there's a letter of intent that's due from practices by April 23rd, and the template for the letter of intent can be found on the website for the Oncology Care Model, which is found at innovation.cms.gov/initiatives/oncology-care.
All right, thank you for that. So I'm just going to mention that there was an accompanying editorial in the JOP titled Medicare Innovation Center Oncology Care Model, A Toe in the Water When a Plunge is Needed by Drs. Polite and Miller. And have you had a chance to read the editorial?
Sure, we're aware of that editorial.
Okay. So,
and we appreciate their thoughts.
Yeah, I think everyone is working towards the same goal here. ASCO has worked on developing a separate model, something called the Consolidated Payments for Oncology Care proposal. And so how would you address the criticisms of Drs. Polite and Miller when they say that the CMS's proposal simply perpetuates the weaknesses of the current fee-for-service model?
Well, I think it's important for me to say that there's a definite interest on the part of CMS in finding a better oncology payment model. And the OCM, with its focus on quality measures and alternative payment mechanisms, is simply the first example of that. At the same time, we have to be aware of potential unintended negative consequences, so we have to move forward carefully and thoughtfully as we change the oncology care payment system. The purpose of the OCM as it's presently structured is to help us identify the best path forward into a better oncology payment system. By using the total cost of care as the benchmark against which performance-based payments are made, CMS is incentivizing value and quality of care over volume of care. Second, a consolidated payment system using monthly payments does not address some of the very important cost drivers in oncology, such as avoidable emergency department visits and hospitalizations, as well as the more efficient use of medications, diagnostic imaging, and laboratory tests. So at this time, we are looking forward to having the oncology care model begin for practices, hopefully in April of 2016, and we're looking forward to learning from that process to improve the oncology payment system still further.
That sounds very reasonable. One of the concerns that was raised in the editorial was the potential issue with the 6-month episodes, that perhaps this might create an incentive in practices to drag their treatments out beyond 6 months so that they would initiate a second episode that would have a relatively low cost and yet still be help them get under the benchmark goal.
Certainly, we're aware of that potential for gaming of episodes of care, and we haven't addressed that completely yet. But one potential solution is that the first episode of care for a specific cancer diagnosis is greater than the second episode of care for a cancer diagnosis. So, for instance, if the care should be completed in 6 months or 5 months, but for whatever reason it drags out to 7 or 8 months for whatever reason, some legitimate medical reasons, some perhaps gaming opportunities on the part of less than ethical physicians, then the second benchmark of care for the second episode could conceivably be less than the first episode to sort of help correct for that problem.
Okay, well, that certainly might help. So, is there anything else that you would like to make sure our listeners know about the Oncology Care Model or CMS's program?
I think just a personal statement on my part is as I mentioned before, I've been a pediatric oncologist for about 25 years now, 24 years, and I've been through the managed care model, and I think this is a much better model for taking care of our patients. It lets us use our best judgment to provide good care and to provide efficient care for our patients. And so given the various alternatives out there for trying to bend the cost curve, I think this is an excellent model to test. And
it certainly is a huge problem that we need to start trying something. And so I think this is certainly an excellent first step. So thank you, Dr. Kline, very much for joining me today and having this conversation about your paper and about the Oncology Care Model.
Thank you very much for having me, and I enjoy the chance to talk with you and your listeners.
I also want to thank the listeners who joined us today on this podcast. The full text of the paper is available at jop.ascopubs.org under Early Release Articles. Please scroll down to February 17th, 2015. Don't forget that you can also read the JOP and access these podcasts on your smartphone or tablet with the ASCO Journals mobile app, available on the iTunes Store or in Google Play. This is Dr. Nathan Pinnell for the Journal of Oncology Practice signing off. Thank you for listening.